So good afternoon, everyone, and welcome to this Australian Centre for Value-Based Healthcare webinar. I'm Lisa Roby, the Engagement and Business Director here at the Australian Healthcare and Hospitals Association, and it's my pleasure to be your host today. Before we get underway, I'd first like to acknowledge and pay respects to the traditional owners of the lands on which we meet, wherever we may be for today's webinar, and to pay our respects to elders past and present. I also extend that respect to any Aboriginal or Torres Strait Islander people who are joining us here today. Today, for this webinar, we are joined by Professor Amanda Walker, who's the Clinical Director at the Australian Commission on Safety and Quality in Healthcare. The Commission recently published the report, The State of Patient Safety and Quality in Australia, 2019, and the report includes information on key advances in safety and quality, including the prevalence of common safety risks, the action taken to identify and drive delivery of appropriate care, and the Commission's approach to value-based healthcare. Amanda has kindly agreed to take questions at the end of her presentation. However, you're welcome to type them out during the webinar. You'll find a Q&A box at the bottom of your screen where you can lodge your questions as they occur to you, and then we'll work through them at the end of the session. And with that housekeeping underway, I'd like to pass over to Professor Amanda Walker.
Okay. Welcome. We're just, okay, I hope you can all see the screen now.
Not yet, Amanda.
Okay, let's just click back on share. Is that, wait a minute. There we go. Share. Screen sharing has failed to start. Wait a minute, let's just try one more time. Oops. Clicking share and there, is that working?
Perfect.
Excellent. Okay. All right. Thank you for that introduction, Lisa. As you've heard, we're here to talk about the State of Patient Safety and Quality in Australian Hospitals 2019, which is a report that was released by what I'm going to refer to as the Commission, but technically is the Australian Commission on Safety and Quality in Healthcare. But it's a bit of a mouthful, so we just tend to refer to it as the Commission, although recognising that there are many commissions. So I too would like to acknowledge the traditional owners of the land that we're meeting on. Here in Sydney, where I am, is the Gadigal people of the Eora Nation, who've lived on the southern shores of Sydney Harbour for more than 40,000 years. But I'd like to also pay my respect to elders past, present and emerging, and take a moment for all of us to remember and acknowledge that Aboriginal and Torres Strait Islander health outcomes are not equal to that of the rest of the community, and we all have an opportunity to address that. And I'd like to thank you for the opportunity to talk with you today and to share some of the information in this report. As you heard, I work here at the Commission, and my background, like my friends, when I say I work here 4 days a week as a clinical director, say, oh, she's gone to the dark side of the force. I'd like to point out that on the 5th day, I do practice as a palliative care specialist, and I am, a normal everyday clinician. And what that means is that I get to see things both from the perspective of the big picture and the system, as well as dealing with it on the cold face and at the ground. So, so when I look at this report, I'm looking at it both from the perspective of the broad system, but also how do I apply this in my weekly practice? So here we have the cover of the State of Patient Safety and Quality in Australian Hospitals report, which you can download from our Commission website. And it's 84 pages long, so I'll just be flagging that I won't be able to cover every bit of it in incredible detail, and I will naturally be drawn to the things that interest me most. So in the same way that when I look at a bookshelf, I am drawn to Colin Firth and his Mr. Darcy outfit, and I will immediately be drawn to Jane Austen. And within the report, I will be talking about highlights of some of the things that mean the most to me. So the first thing that I wanted to cover was some of the international and national safety and quality milestones, and just reflecting back on what's happened in the last few years. So going back to 1991, the Harvard Medical Practice Study came out, and in most states in the country, people started to actually put in place formal complaints mechanisms for patients. By 1995, the Quality in Australian Healthcare study was published, and then there was a professional indemnity review in Australia in 96. In 2000, the To Err is Human report came out in the US, and an organisation with a memory came out in the UK. And what was then the Australian Council for Safety and Quality in Healthcare was established. And then in 2001, Crossing the Quality Chasm in the US, but there was also a report about some serious clinical issues in the Bristol Royal Infirmary in the UK. And there was an inquiry into the first, into King Edward Memorial Hospital in Australia. By 2002 to 2004, hospitals were required to report sentinel events according to a national list, which was the first edition of the Australian Sentinel Events List, and the first national open disclosure standard was implemented. Moving along to 2006, the Commission was established, so the Australian Commission on Safety and Quality in Healthcare was established, and at the same time there was a requirement for hospitals to introduce electronic incident management systems so that we could actually track what's happening in services around the country. By 2011, the Australian Charter of Healthcare Rights was endorsed, and the Australian Safety and Quality Framework for Healthcare was endorsed by the Health Ministers, by RMAC, and the Australian Health Service Safety and Quality Accreditation Scheme was implemented. That first edition of the national standards and the accreditation against them started in 2013, and over the next 5 years, more than 1,330 hospitals and day procedure services were assessed. And then, of course, just like the Harbour Bridge, once you've finished painting one end, you have to start again at the other. So the next edition was started to be worked on. And then around the same time, a group of clinicians came together to develop the Hospital Acquired Complications List, which I'll talk about in a little bit. And the National Model Clinical Governance Framework was released last year. And there have been 3 Australian Atlases of Healthcare Variation, 1, 2 and 3. And so this year, we've started accreditation against the second edition of the National Safety and Quality Health Service Standards, and the new accreditation scheme has commenced. And as of July last year, there was an integration of HACS into the funding model, and we'll talk about that as we get to it. And so moving into the future, by 2020, what we're really working towards is a common set of safety and quality metrics and public reporting of safety and quality data using the Australian Health Performance Framework. So as we're moving along, really what we're moving towards is towards transparency. We're trying to get to a point where we can actually truly examine what's happening in Australia. And there's transparency for the purpose of understanding what is happening and actually shining a light and making sense of what is happening. But also there's transparency in terms of the community and how do we explain and share with the community what's happening in our health services around the country. And all of that work over the last kind of 40 years has been really working towards these 4 principles about being accountable to the community, minimising harm, increasing reliability, so all of the good things we want to do for patients, we do them all the time, and implementing sustainable change. And the report is, shall we say, a little bit dry, and this is my version of non-sustainable change. I saw this on Facebook, it is definitely not in the report. But the 6-second, 6-second 6-pack is not really going to last for long. It's not sustainable change. It's not going to make a difference in the long run. So I want to stop for a moment and ask a few questions. How do you know your facility is doing a good job? How do you know that each team or each department or each ward or each unit in your facility is doing a good job? How does the local health district know that your facility is doing a good job? And how do patients and the community know you're doing a good job? These are the questions that we ask ourselves, okay? And it would be really nice if we could all say, yep, we're nailing it. We're getting it all right all the time. But that's not necessarily the case, and we don't always get to have the satisfied smile or the success baby. And when it's left to ourselves to estimate how we're performing, there's a bit of a tendency to overestimate. So it's called an overconfidence bias, and it's reflected beautifully in this NRMA RACV survey from 2008. They recently repeated it to astoundingly equivalent figures. 94% of male drivers believe they are better than average drivers. And in fact, it's very sexist of me because 86% of female drivers believe they are better than average. And clearly that doesn't compute with the mathematics. We can't all be better than average. And you may think that's not got nothing to do with healthcare. But there was a survey of board members in Victoria, and they call it the Lake Wobegon effect because Lake Wobegon is a town written about by an American writer called Garrison Keillor, and it's about a little town in Minnesota where all of the children are above average. And when you look at how board members assess the performance of their health service compared with other health services, only one board member on one issue in terms of a safe and skilled workforce thought they might be worse than other services. About 20% thought they were about the same in most things, but really between 70 and 80% felt that in all of these issues, the quality of care, the skilled workforce, experience or satisfaction of patients with healthcare, and identifying, managing and reporting healthcare incidents, really all 80% of us are better than everybody else, or potentially much better than everybody else. So if it's left to us, we tend to overestimate how we must be doing or how we might be doing. So how can you tell if you're nailing it? You have to measure. Samuel Shem in The House of God points out that if you don't take a temperature, you won't find a fever. And we won't know who's doing well, and we won't know who's not doing so well unless we actually measure. And so that's where we get to patient safety surveillance, which is one of the big themes of the Safety and Quality Report. And one of the crucial issues is that measurement is fundamental to improving safety. Meaningful metrics are required to understand what the major safety issues are across the care continuum, to proactively mitigate patient safety risks, and to stimulate improvement. And there's really strong evidence that the provision of relevant and importantly timely clinical information to clinicians and managers is an effective driver of safety and quality improvement. If we don't know we have a problem, we won't address it. And so we need to know, and we need to know in a timely manner so we can do it and we can address it in a timely manner. So here's where we get to the National Safety and Quality Health Service Standards. And I love this logo because you can interpret it either as a person saying, yay, we're working on the National Safety and Quality Health Service Standards. Or you can reinterpret it as Edvard Munch's The Scream, with someone with their arms raised up screaming, I have to deal with the National Safety and Quality Health Service Standards. And sometimes you can feel both of those ways on the same day. Clearly, there are significant challenges for services around the country, and I say that as a clinician who's responsible for ensuring that the care I provide meets the National Safety and Quality Health Service Standards, or the national standards, as I'm going to call them from this point on. Now, I'm hoping that you're all familiar with the fact that we have a second edition of the national standards out. As I said earlier, we started accrediting against them this year. And so a number of them will be very, very familiar to all of the health services out there, but you will notice that there have been some changes. So instead of 10, we have 8. And the comprehensive care standard is a new standard that combines the old pressure injuries and falls standard and looks at mitigating some of the other serious risks for patients with complex needs. And then the clinical handover standard has become communicating for safety. So before we talk about the second edition, though, it's worth stopping to reflect for a moment and looking at what are some of the outcomes of the first edition of the national standards. And there have been a number of really well-documented changes across the country. And I've just taken an absolute highlight of them, but there's been a drop in the yearly number of MRSA bacteremia cases from 505 to 290, so we've nearly halved that. Then there's been a decline in Staph aureus bacteremia rates from 1.1 to 0.76 cases per 10,000 patient days. And there's been a decline in almost 1/2 of the national rate of CLABSIs, or central line associated bacteremias, So that's dropped from 1.2 to 0.64 per 1,000 line days. And you may say, oh, that doesn't sound very impressive. But I'd like to point out that when I was a medical student, we were basically taught in the late 80s and early 90s that you couldn't make a difference to any of these because all of these things happen the moment you breached the skin, there was a risk of infection. And what's actually been really clearly demonstrated is that by careful attention to hand hygiene and to aseptic non-touch technique and providing excellent care and sterile care, we can actually make a dramatic difference to these problems that were once considered inevitable, and clearly they are not. We can actually make change and make improvement. Some other highlights: the number of hospitals with antimicrobial stewardship programs has increased from about a third to 98% by 2015. Formularies restricting use of broad-spectrum antibiotics has increased dramatically around the country. And through the National Inpatient Medication Chart audit, we know that there's dramatically better documentation of adverse drug reactions and clear documentation of medication histories through the Medication Safety Standard. And then in terms of blood use, there's been a dramatic decrease in red blood cell issues from about 800,000 units to 667,000 units. And really interesting to me, declining rates of in-hospital cardiac arrests and ICU admissions following cardiac arrests. So in New South Wales, there's been a 51% decrease. And in Victoria, there's been a 20% decrease. And then across the system, early warning and track and trigger tools have been implemented in 96% of recognition and response systems, compared with only about a third of them in 2010. And most hospital boards and their governance equivalent have reported that as a result of using the National Safety and Quality Health Service Standards, the board actually understands and has been able to enact their roles and responsibilities about patient safety and quality. So boards are not just responsible for the financial outcomes of their local health districts, but also for the safety and quality outcomes in their local health district. Now, that doesn't mean that things are perfect and that everything has been fixed and we can all go home. There are still a number of areas that we require further action to support safety and quality improvement. So one of the key ones is full implementation of an open disclosure response consistent with national and local standards. Ensuring that incident management and investigation systems provide adequate surveillance to recognise major safety lapses and risks. And implementing corrective action in response to identified patient safety risks and lapses, and making sure that there's a communication loop back to those who report. And then establishing complaint management systems that include partnership with patients and carers. And then the last ones are about making sure that we've actually truly implemented informed patient consent and ensuring a robust and positive safety culture, and clearly understanding the roles and responsibilities of governing bodies, the executive, clinical teams, and clinicians in the space of clinical governance. So now I want to spend a moment talking about some of the different forms of patient safety surveillance. So you'll all be familiar, hopefully, with sentinel events. Hopefully you won't have experienced them or witnessed one. They're what we also call never events. And so they're the subset of clinical incidents that are wholly preventable and result in serious harm to or death of a patient. So I just want to remind you of what is on the new sentinel events list that came out last year. So it's been curated and reviewed, and some of the ones like maternal death have been removed because some of them are not wholly preventable. So the new list covers, and you'll notice that all of them define as resulting in serious harm or death. So it's not just a minor procedure which did not have serious harm or death. It results in serious harm or death, and it covers surgery on the wrong site, surgery on the wrong patient, the wrong procedure performed on a patient which resulted in harm or death, serious harm or death, unintended retention of a foreign object in a patient after surgery, resulting in serious harm or death, then hemolytic blood transfusion reactions from ABO blood type incompatibility, then suspected suicide of a patient in an acute psychiatric unit or acute psychiatric ward, medication errors, use of physical or mechanical restraint resulting in serious harm or death, discharge or release of an infant or child to an unauthorised person, and use of an incorrectly positioned oronasogastric tube resulting in serious harm or death. The good news is that the number of sentinel events are clearly slowly decreasing across the country. And so you can actually see they've dropped by almost a third in a series of years. And I'm just going to, I don't want Windows to do anything to me. Okay then. So just flagging some of the variation around the country. So this is state by state for the different sentinel events. You'll notice that suicide of a patient in an inpatient unit and retained instruments or other material after surgery are the most common sentinel events on the old list. And so you can see that there's variation in them across the states around the country. And then I wanted to spend a moment just talking about critical incidents and open disclosure and why we think this is so important. And the first thing is, what actually is it? And open disclosure is really important. And it starts with an apology. And there are a lot of clinicians who still believe the outdated perception that if you apologise, you are admitting legal liability. And this is incorrect. And in fact, there's really good evidence that if you apologise, you're much less likely to actually be sued. So start with an apology, and I'm sorry for what happened to you. Then an explanation of what actually occurred and discussing what the experience was for the patient, what they felt, and what the consequences have been for them. And then describing what steps are going to be taken to manage the incident and prevent recurrence. So they're the 4 steps that you need to make sure that you cover when you're doing open disclosure. And so across the country, Australia has actually instituted open disclosure policies, and that's as a regulatory requirement, and they're all guided by the Australian Open Disclosure Framework. Now, why do we think this is so important? Well, it's because it's got a whole series of benefits. For patients, their families and carers, it can allay feelings of anxiety and abandonment after harm, and it has been shown to have a cooling effect on desires to litigate. But most importantly, it's most commonly motivated, these anxieties are motivated by patients who simply want to find out exactly what happened, especially if they feel like people are hedging and evading them, and if there's been a lack of open communication, because it's a natural human response that when someone is questioning you, that you feel a bit defensive. And then also taking into account for providers who some would describe as second victims of harm, open disclosure and actually speaking frankly and openly with the patient can actually be part of a healing process. And in the bigger picture, as part of our health service organisations, when organisational leaders endorse and support open disclosure, it contributes to what we call a just culture, and it makes the system safer for all of us. The next thing I'd like to focus on are hospital-acquired complications. So this was a big body of work, and it actually started just with a group of clinicians gathered around a table looking at a whole series of adverse clinical outcomes and trying to work out by these 4 criteria whether they might be appropriate for a list of hospital-acquired complications. And the criteria included preventability, patient impact, service impact, and clinical priority. So in terms of preventability, it doesn't have to be 100% preventable, so it doesn't necessarily eliminate the risk of that complication. So for example, we recognise that only 40% of delirium is preventable. However, the patient impact and service impact is so massive that the group felt that it was really important to include them to make sure that we work on decreasing the incidence of delirium. Now, the first body of work was purely clinicians, but then when the government sees something good, it likes to get on board. So this is actually COAG, and on the 1st of April 2016, all of the jurisdictions around the country agreed that they wanted to take action to improve the quality of care in hospitals and reduce the number of avoidable admissions by improving hospital pricing mechanisms to reflect safety and quality by reducing funding for unnecessary or unsafe care, and working to reduce hospital-acquired complications, and also working to reduce the number of avoidable hospital readmissions. And why did they think this was such an important issue to address? Well, just as an example, in the last financial year, in 2017-2018, admissions associated with HACs were estimated to cost $4.1 billion, or 8.9% of total hospital expenditure. So that's a massive, massive, massive amount of money that could perhaps be better spent in other endeavours. And as a palliative care clinician who would like to support everybody who wants to die at home to safely die at home, I would love to get my hands on a little bit of that money to support the most important health outcomes for my patients as well. So the good news is that they are slowly and steadily decreasing, and that focusing on them with a pricing signal. It's not a complete loss of funding like for sentinel events. It's actually just a pricing signal where there's a risk-adjusted approach to decreasing your funding for that hospital-acquired complication. That approach actually has started to drive a real focus on these hospital-acquired complications. So what are the most common ones? Well, you can see that the biggest one is healthcare-associated infections, followed by cardiac complications, delirium, medication complications, and further on into the smaller groups. Now, I don't want to focus on any of the detail in this slide, but what I just want to point out is that the numbers are massive. 140,000 last year, and numbers can sometimes feel distant. But when you frame that in terms of each of those 140,000 people was someone's mother, someone's father, someone's sister, someone's husband, someone's daughter, someone's son. And when you contemplate from that from the personal perspective, nobody wants any of these ones. You know, they're all complications we'd like to avoid. So you can see, as I said, that the rates are slowly decreasing, which is a good thing. And in terms of, for example, healthcare-associated infections, why are they decreasing? Because there's been a massive focus on them. So the National Hand Hygiene Initiative, development of standard definitions for the surveillance of SABs and CLABSIs, their National Surveillance Initiative for the Prevention of HAIs, contributing to a national definition of SAB and reporting and monitoring of SAB rates nationally, antimicrobial stewardship programs, the Clinical Care Standard in Antimicrobial Stewardship, clinician capacity building, the Australian Guidelines for the Prevention and Control of Infection in Healthcare in conjunction with the NHMRC, strategies to reduce MROs and the surveillance of surgical site infections, and AURA, the Antimicrobial Use and Resistance in Australia surveillance system, as well as all of the activities undertaken by the states and territories. So we are slowly but steadily making significant headway because of that. And another example is in the increase in the overall hand hygiene rates in public and private hospitals from 63%, which on one level is a national tragedy, up to a much better 84% in 2017. And I've already flagged under the national standards this decline in SABS rates and decline in MRSA bacteremia cases and a decline in SABCs. So we are making headway, and this is a really good thing. And the Commission has gone further and actually started to set within this document some national goals. And again, I don't want you to go into the detail of this slide. It's all in the report there for you to process at a later time. But what I want to flag is that the national goals are actually divided up by the type of facility you work in. So you can see these principal referral hospitals here, and then public acute group A hospitals here, and public acute group B hospitals here. And so what we're saying is not, we have set a national target of 0 and you all must achieve 0. What we've actually said is, depending on what kind of facility, we want you to work to lower the incidence of these hospital-acquired complications to the level of the better performing hospitals. And I'll show you some examples. So here we have for healthcare-associated infections, you can see the string of pearls graphs on the left. And to be really kind, we've actually excluded the lowest 10%. So the best performing 10% we've excluded just in case there are issues with coding and with coding data sources. So we've said everybody gets a free pass on the best performing 10%. But from that point in the blue, we have the next best 25% of facilities. And you can see, depending on the type of facility, is it principal referral hospital, so a teaching hospital, a tertiary or quaternary facility, or smaller district hospitals, you can see that we are aiming to get everybody practicing to the level of the HAC rates in these facilities. So all of these facilities in grey, particularly this one up here and this one up here, we'd like to get you to learn what's happening in these facilities here and how can you get your rate down to those who are providing this better level of care. And so we're not asking the impossible. We're not asking for people to get it down to here or even to here. We're saying, let's perform at the rate of the top 25% of Australian hospitals. So let's learn from what people are doing. So you can see that that target rate is significantly different compared with principal referral hospitals here. Sorry, the mouse keeps dropping away. Here, compared to Group A, where it's only 84, compared to Group B, where it's 52. Why though? Because if we could do that level in each of those facilities, it will result in nearly, in 11,000 fewer HAIs, and that would save, 230,000 bed days and $459 million. And that would be, an opportunity to reinvest that in other aspects of the health system. So we're not saying be perfect, everyone must be perfect. We're saying let's learn from the people who are doing this really well and all work to get to that level. So again, with venous thromboembolism, you can see that there are some services up here who are not performing to the level. And in fact, they're nearly double or triple the rates that are happening in the better performing services. And again, significant savings. In terms of pressure injuries, again, $60 million that we could do other things with. And you can see that in this circumstance, again, across all of them, there's really significant variation. And yet, some services are at this level, some services are down here. How do we learn from the services that are down here so that we all provide that standard of patient care? With surgical complications, this one is really interesting to me because you can see very clearly how having patients with complex comorbidities or providing much more complicated surgery means that the rate of surgical complications in principal referral hospitals is dramatically higher than the rate in Group A and Group B hospitals. And that means that the target in principal referral hospitals is 10 times higher than the target in Group B acute hospitals. But again, nearly $100 million could be saved and reinvested in our health system with a really significant value capture if we actually were able to ensure that all of the services up here in grey were functioning at the level of the services in blue. The same for perineal tears and the long-term consequences and harm for women who experience them. And then for delirium, and delirium is really interesting because we recognise that not all delirium is preventable. However, some people are having dramatically lower rates of delirium than others. And we can learn, if we're up here, from the people down here to improve it. The same with medication complications. There's a dramatically higher incidence here than there is down here, nearly 3 times as high. So we have opportunities to dramatically increase, and again, 3 times higher in the principal referral hospitals than in the Group B hospitals, reflecting the complexity of the patients and the comorbidities of the patients. But $120 million could be reinvested if we better address these. So that's why we've set these targets to work towards them. So in order to do this, for me, one of the important things about the HACs is that as a clinician, I don't have to spend a lot of time auditing clinical records. This information will be automatically collected and I'll be able to learn from it without having to sweat blood and tears to actually troll through medical records to get to it. And so we need to make sure that clearly the data is true, and we need to ensure that we're measuring accurately, and we need to embed monitoring our HACs as a part of a national strategy to do that. And so in order to do that, we need to look locally at our data, and there may be particular reasons why particular problems are more common in your area. That's okay. We just want to understand it. Then we want to model on excellent services and better plan our care so that we can take excellent action. and then review the outcomes so that we can make sure that we're continuing to improve. The Commission has put out some resources about the hospital-acquired complications, and so just want to flag that they're available on our website or on the Australian Nursing and Midwifery Foundation website. But I think one of the most important things is just to stop for a moment and recognise, and this is a beautiful quote from Douglas Adams, who wrote Hitchhiker's Guide to the Galaxy. He said, "Human beings are almost unique in having the ability to learn from the experience of others, are also remarkable for their apparent disinclination to do so." And we won't do anything about hacks if we don't realise that we have a problem. And one of the challenges locally is to recognise, what are your issues locally? You know, in my facility, what are we doing well at and what are we doing not so well? And where do we want to focus our quality improvement activities to try and bring rates down? Okay? But more than that, we want to find out who is doing it well and how can we learn from them? What are the things that they're doing that make a difference to these outcomes, and how can I implement them locally? What can I learn from fellow clinicians around the country? And it's a matter of not just looking within our own states, but looking nationally at who's doing this really well. Because I could be the best performing hospital in my state, but my state might be the worst performing state in the country. So we need to actually look broadly across the country, and this is where national information is really important and can make a big difference, because then we can understand who are the leaders, what are they doing well, and how can we all implement that. Okay, I'll just take a quick breath. So, on to avoidable hospital readmissions. So this was another focus of RMAC and COAG, and they wanted us to focus on avoidable hospital readmissions. And why? Because they're costly and because rates remain relatively steady. We haven't managed to make dramatic action in this space. One of the issues is actually about improving data collection so that we can inform local quality improvement. And one of the challenges is actually linking data so we can actually track a patient from one facility. Like, it's easy to track them if they're readmitted to that facility, and we can track them if they're admitted to facilities within local health districts. It becomes more challenging if, for example, they move from a private facility to a public facility, or from a public facility to a private facility, or from a facility within one LHD to a facility within another LHD. And so we're working to actually properly track this so we can get a better understanding. And this again is another insight into the safety and quality performance of the health system. And so, you know, an avoidable hospital readmission has been defined along the same criteria as the HACs, in terms of, is it preventable, does it have a clinical impact, does it have a service impact, and is it a clinical priority? But it's also defined as being a readmission occurs when a patient has been discharged from hospital and they're admitted again within a certain time interval, and that readmission is clinically related to the original admission and has the potential to be avoided, either through improving the clinical management or through appropriate discharge planning in the original admission. And the next slide I want to share with you is just to highlight the significance of that appropriate clinical interval, that appropriate time frame. Because depending on the pathophysiology of the actual cause of your hospital readmission, there's a dramatic difference in the time frame. So you'll notice that this list is remarkably similar to the HACS list, and that's because it was based on the HACS list, but there were two areas added to it, and that was nausea and vomiting and pain. Oh, sorry, there were three areas: nausea and vomiting, pain, and constipation, because they're really, really frequent causes of readmission to hospital, and it's often because we sent people home on analgesics without appropriately preventing the side effects. Sorry, palliative care physician coming at me there. So I highlighted bloodstream infection because you can see that because of the pathophysiology of a bloodstream infection, the time frame for this one is actually really, really short. Beyond that, it's hard to demonstrate that it's related to the hospitalisation. But on the next page, you'll see that venous thromboembolism is actually a really long readmission interval of 90 days. And the clinicians in the Curation Advisory Group were really clear that it was important to send a signal that 75% of all community-acquired venous thromboembolism actually occurs in the 90 days following hospital admission. And that when we're in hospital admission, So when the patient is in hospital, we actually need to work to dramatically decrease VTE, not just while they're in hospital, but for the 3 months afterwards when their risk is dramatically increased. And that increase in risk can be up to 100 times. So it is really important. And in fact, I would argue that VTE should be called hospital syndrome, not economy class syndrome. But just flagging the variation, so 2 days for a number of them, up to 90 days, depending on the clinical pathophysiology of the underlying problem and how tightly it's linked to the original admission. And just reflecting what the government have pointed out, that while the number and the cost are increasing, the rate has just remained steady and we haven't managed to actually start to decrease that yet. And that's where we're aiming. So the next thing I'd like to share with you is about healthcare variation. And there have now been 3 atlases of healthcare variation in Australia. The third one was released last year. And just one of the components about it is about, one of the topics covered, as an example, is about early planned caesarean section without medical or obstetric indication. So clearly recognising that either for the mother or for the baby, there may be indications to perform a caesarean section earlier than this. But I need to flag that, in fact, between 42 and 60% of planned Caesars before 39 weeks didn't have a medical or obstetric reason. And the consequence of that is actually really significant for the baby. And so we want to ensure that as many pregnancies as possible continue as close as possible to term, and that elective Caesars don't happen without a medical or an obstetric reason. Okay. So I won't go through each of the findings of the atlases, but I just wanted to flag more broadly, why does variation occur? And when we explore variation, what might it identify? And so when you look at rates of an intervention that are substantially higher or substantially lower in some areas, it may highlight that clinical practice isn't supported by evidence-based guidelines. So the example that comes to mind for me is that in the eastern suburbs of Sydney, the rate for colonoscopies is 30 times higher than in other parts of Australia. And that clearly is not along evidence-based guidelines, and that the rate of colonoscopy in that area of Sydney is, is excessive and needs to be addressed. So then one of the other issues is that inequity of access to evidence-based care and the need to deliver services more fairly. It also may reflect higher rates of private health insurance in areas of greater socioeconomic advantage, and it may identify inadequate system supports for appropriate care and the need for changes in training or financial incentives. Or it may be that there's uncertainty about the intervention's place in therapy, and we actually need to explore and examine the data to identify its benefits and its harms. And so just as an example of this, I wanted to flag the example of knee arthroscopy. And you can see that following 2014, we start to see a slow and steady decline in the rate of knee arthroscopy around the country. Why has this happened? Well, a lot of people have been involved in working on this, but in terms of what the Commission has been working on. So in 2015, we published the Atlas of Healthcare Variation, which actually showed a really large variation in knee arthroscopy rates around the country. And the Atlas recommended developing a clinical care standard and resources for consumers. And we recommended that the Medicare Benefits Scheme review changes in funding. And then a documentary on knee pain for consumers was released, and the clinical care standard on osteoarthritis of the knee was developed and released. Then indicators for monitoring osteoarthritis of the knee were specified. And in 2018, the Medicare Benefits Scheme has demonstrated through its data systems that there's been a reduction in knee arthroscopy. And just this year, we've actually released a decision support tool for patients when they're considering their options in terms of managing their osteoarthritis of the knee. So there's been a large body of work to address that. Now, we're about to talk about value-based care. And one of the challenges in this system is often people are just so busy. And I love this Winnie the Pooh quote from A.A. Milne from the book Winnie the Pooh. Here is Edward Bear coming downstairs, bump, bump, bump on the back of his head behind Christopher Robin. It is, as far as he knows, the only way of coming downstairs, but sometimes he feels that there really is another way, if only he can stop bumping for a moment and think about it. So now I want to talk for a moment about value-based care. And lots of people use the term, and so I thought we should define what the Commission is talking about. And we're talking about value-based care is about achieving the best care possible for each patient while maintaining an efficient use of resources. And why is it important? Well, it's a common goal for patients, clinicians, provider organisations, administrators, governments and policymakers, all of us working together, and it places patient outcomes as the focus of health system performance. And in order to create high-performing health systems, we need to deliver services that improve health outcomes that matter to patients. We need to understand and improve the experience of both staff and consumers, and we need to ensure the efficiency and effectiveness of healthcare delivery. So how's the Commission working to do this? Well, we've got 5 key areas. The first is focusing on people, understanding and responding to what matters to consumers and staff. Then the next is measuring and reporting on safety and quality, and using all the data that we were talking about earlier to identify, monitor and report on patient experience and outcomes, staff experience, pardon me, costs and variation in practice. So this means focusing on a new generation of outcome indicators that'll show how well health systems are serving people's needs, including patient-reported experience and outcome measures. Then we need to use evidence-based guidance and policy and using evidence to inform clinical practice and improvement, and we're working on that. And we're working to strengthen clinical governance by embedding accountability and strategies for safety and quality within organisational governance. And we're working to embed safety and quality into national systems using information and knowledge about safety and quality to inform those national systems. And I won't read all of the data on this, but just wanted to flag this figure, which identifies some of the different strategies that we're using. So for example, when we're talking about we've covered that before. When we're talking about, for example, strengthening clinical governance, we have the first standard as part of the National Safety and Quality Health Service Standards, and the accreditation scheme, the National Model Clinical Governance Framework, the Clinical Trials Framework, Electronic Medication Management Framework, and e-health systems. Then looking at focus on people, we have the Charter of Healthcare Rights and Policy in terms of person-centred care, health literacy, shared decision-making, comprehensive care, clinical communication, teamwork and informed consent. The RPECs, which I'll cover in a moment, PROMS, safety culture, the National Model Clinical Governance Framework, Australian Safety and Quality Framework for Healthcare. So there's all these different strategies that we're using basically to address each of these 5 key areas, with, of course, people in the middle of it. And why do we think person-centred care is so important? Well, because it's better for the patient and it's better for the community. It's also better for our workforce experience and it improves well-being of our staff. It also promotes better clinical outcomes and it improves safety and quality, and it also saves money that we can invest elsewhere. And so how do we translate person-centred care to the big picture? And how can we learn from the places that do this really well? And so I just wanted to flag that one of the things the Commission did was last year, it produced a document about the attributes of organisations that excel in person-centred care. And so you can see that there are themes. You know, the places that do this well, do it well for the same reasons. And they focus on things like purpose, strategy and leadership, people, capability and culture, their governance systems, the partnerships that they make, how they use technology, what they measure, and how they use that measurement to improve care, and how they actually deliver comprehensive care in a day-to-day manner. So you can actually spend some time looking through this document to identify how can we do this locally, how can we turn our organisation into a high-performing person-centred healthcare organisation. And the last thing I thought I'd mention is just what we think is really important to effective measurement. And that's making sure that robust health information standards and clinical indicators are available for health service organisations and systems to use, and that there's a model for local, regional and national monitoring of patient safety and quality, and then that we support consistent and transparent public reporting on safety and quality by all sectors of the health system, both public and private sector systems. I won't cover these in detail, just to flag that they're in the document and just to remind us about the guiding principles for safety measurement and monitoring. And then to mention that Australia has sometimes been described as lagging behind and as being a little bit less advanced than some countries when it comes to public reporting of healthcare quality and safety. And a number of reports have signalled a commitment by the Australian government for increased transparency in reporting about health services, particularly to promote informed decision-making by the people using those services, and also to contribute to quality improvement and quality assurance. And at the local level, there are varying degrees of public reporting. And so some have really well-developed public reporting mechanisms, like, for example, South Australia. Shout out to all the South Australian peeps online. And Queensland and New South Wales, to other perhaps less developed models. And so although most hospitals in Australia measure and collect information on all of these different issues, it's not always clear how the information is fed back to their clinicians and how they use it for local improvement. And, you know, I reflect as a clinician, I know that there's a whole lot of monitoring of different things, but, you know, nobody sends me a list of, for example, the healthcare associated infections that I have contributed to. And I have no idea whether I'm good at this or bad at this, okay? And so we need to make sure that the information we're collecting actually reaches our target audiences so that people can use it to improve where they need to. And so some potential indicators that could actually be mapped to reporting measures for safety and quality include in the safety domain, obviously compliance with the national standards, but some patient outcomes like mortality and avoidable hospital readmissions, and then reviewing adverse events like HACs, SABC surveillance, and the Sentinel events list. Then in terms of appropriateness, patient-reported measures, so RPECs, and patient-reported outcome measures, and then staff safety culture. And there's shortly there'll be a release of patient safety culture survey. A lot of states have one, and we're setting up one for the states that don't currently have one in use that will be released in the not too distant future. And just to flag, the RPECs, which is the Australian Hospital Patient Experience question set, covers these 6 simple questions. Am I cared about? Six simple topics. Am I cared about? Am I informed? Am I known? Am I treated as a human being? Can I get the right care at the right time? And my experience of high quality and safe clinical care. The last thing I want to mention is about the work we've done in evidence-based policy and guidance. So the Commission's work involves the development of evidence-based policy and guidance and includes undertaking and using research to inform new policies and guidance to improve the safety and quality of healthcare, supporting data collection and analysis to inform decision-making approaches, and developing policies that incentivise the use of evidence-based approaches. And so we've developed a range of clinical care standards describing quality care for a range of conditions where there's been variation in practice. And a lot of these clinical care standards have come up because we've identified issues through the Atlas of Healthcare Variation, or it's come up in the application of the national standards. And so to develop a clinical care standard, we pull together a topic working group, and that consists of clinicians, researchers and consumers, and they actually review the current evidence from guidelines and standards, information about gaps between evidence and practice, and then we use their clinical and personal expertise and knowledge of the issues, and we consider the issues that are important to consumers. And so you can see on the right a list of all of the current clinical care standards. Cataract is just about to be published, and peripheral venous access is currently out for consultation. So you can provide feedback on the Commission's website right now. So the clinical care standards actually work in 3 ways. They actually help people know, so they're for the patient, and then for the clinician, and then for the organisation. And so the information is framed around for the patient, what care they should expect for a particular clinical condition to help them make informed decisions about treatment in collaboration with their health professional. Then for the health professionals, what they need to know so they can deliver quality care and have informed discussion about treatment options. And then for the health services, information that they can use to guide practice and also monitor improvement in their hospitals. Then The National Model Clinical Governance Framework was released last year, and I won't spend a long time on it, but I just want to flag what it describes as what its definition of clinical governance is. And I think this is really important because clinical governance is a shared responsibility to ensure that all patients receive the best care. And when we see massive variation around the country, we know that not all patients are receiving the best care. And so that brings me to the end of the report, but I just want to remind us that we're focusing on working towards transparency and working towards providing the best care. And if we want to provide the best care, we need to recognise where we're not providing the best care. And Mother Teresa has a beautiful quote where she says, "Honesty and transparency make you vulnerable. Be honest and transparent anyway." And this is where I think it's really important to overcome some of our feelings of distress and shame if we realise that our service is not doing well in an area. And remember that it's not actually about us and our discomfort at public data, about our performance. It's actually about our patients. And this can drive us and help move us forward to ensure that our patients get the best care and that we learn from the people who are having better outcomes so that our patients and our communities get the best care. And it's all very well for me sitting in the Clinical Commission in my own little ivory tower to be saying, everybody, will tell you what to do. But we actually do need to recognise that it's the clinicians on the ground. It's the people working at the coalface who are actually making the difference to those hand hygiene rates, to those SABC rates, to improving the delivery of blood, to decreasing cardiac arrest rates around the country. And so, your empire needs you. We actually need all of you to look at how can we do this locally? What difference can we make? How can we use this data? And the important thing is that you tailor strategies to your local needs. A really large tertiary or quaternary referral centre in Melbourne will not need the same strategies as a smaller service in an MPS in outback New South Wales or Western Australia. We need to tailor strategies so that they're appropriate in the clinical context that you actually work in. And a reminder, keep calm, you're not alone. And this is the advice line for the National Standards Accreditation process. But if you have a question, you can actually just ring the front desk of the Commission on the number on the website, and they'll actually put you through to the people who can be of assistance to you. So the last thing I'd like to say is a lovely French expression, because in Australian we've got, go you good thing or get into it. But the French have not just good luck, which is bonne chance, but bon courage. And it means I wish you good courage. And I recognise that all of the stuff we've been talking about is really challenging. It's not straightforward. And recognising that you might have a problem in your service and working to improve that problem can be really, really challenging. So I want to wish you good courage to address the issues that you find in your local service. So now I'm going to open it up to any questions, and I'll stop sharing and see where that takes us.
So we do have 2 questions that have been submitted, Amanda. Thank you
Excellent.
so much for your presentation. So Kelvin Billinghurst asked if you have any comment on any new KPIs we're likely to expect at federal and state levels.
I can't speak to that because I haven't got any new, I'm not aware of any incoming KPIs. I have a colleague in the room who's also not aware of any incoming KPIs. So I'd be honest and say that people have a lot on their hands with the national standards and making sure that they're getting up to scratch with them. So I don't know of any incoming KPIs at this point in time. The main issue that I've talked about is the targets for hacks, but they're not a KPI, they're a goal. They're not they're what we think are an acceptable clinical outcome and what the community should be able to expect, because the best services are doing this. So how do we learn from them? But it's not a KPI.
Thanks. We have 2 questions from someone who didn't put their name. So the first is, in a pointed prevalence study published in May this year, it identified surgical site infections as the most prevalent form of HIA. accounting for more than 25%. Given that they're also considered the costliest infection, are you able to share what activities the Commission is looking to implement given its prevalence and human impact?
I'm just trying to think about, because some of this is not in my space of expertise within the Commission. I know that sorry, we're just having a conversation here. Because, look, it is coming up in the context of the hospital-acquired complications, and we're trying to actually ensure that people are aware of what's happening locally in their services. But it is coming up also within the healthcare-associated infections body of work, but I'm not the expert to speak to that. Whoever sent that question in, can I flag that there are people, like there's a clinical advisor who specifically leads that body of work and works with the team, and she'd be much better equipped to talk about what we're doing. If you get in contact with us, my email is just amanda.walker@safetyandquality.gov.au. That's all written in lowercase letters, safety and not an ampersand. But I'm very happy for you to email me, and I can get you in touch with Catherine Davison, who is our clinical advisor in the healthcare associated infections, because she'd be much better suited to answer that question. I'm sorry. It's not my space of expertise. I'm not very good with my hands and definitely not working in the surgical space.
Thanks so much for that. And I might leave the second half of that question because it's a bit similar. But
so it's targeted in that space. Catherine,
thanks so much for offering. There's been a question about if the presentation will be available. With Amanda's consent, yes, we'll make it available on the Australian Centre for Value-Based Healthcare's website.
So I'll forward that to Lisa so that she can put it up on the website. And I'll also flag that the report is downloadable. So most of the information comes directly from the report. So if you want to see more information, a bit more information, and often more data, you can have a play with the actual report document as well. But I'm very happy for the slides to be distributed.
Fantastic. Thanks so much. Sorry. Thanks so much there, Amanda. And we have reached the end of our time, so I will just close off there. Thanks again to Amanda for a great and really thorough presentation. We do hold webinars on topics related to value-based healthcare each month, and the next will be held on the 18th of September. It's going to feature Dr. Jack Cochran, a former leader of Kaiser Permanente in the US, and the author of the recent book, Healer, Leader, Partner. He'll be in conversation with Dr. Jazz Sanai, discussing the role of the physician leader in leading change in healthcare. So definitely a really fascinating conversation to be able to hear. There is already more information about that webinar and how to register available on the Australian Centre for Value-Based Healthcare's website. So thank you all for joining us. Thank you especially to Amanda for a fantastic presentation, and I hope that you're all able to join us again at our next webinar in September.
Thank you.